So today I really wanted to highlight some of the key processes that are involved in developing and implementing training for iCCM. And that's from the initial engagement of partners in the training process to the development of materials, implementation of what was mostly used as cascade training, and some of the post-implementation processes, such as post-learning assessments. And this is really with a view to what worked, what didn't work so well, and what can be done in the future for better iCCM training and implementation of training. Next slide, please. So really the purpose is to look at the effective collaboration between implementing partners themselves and then between partners to support ministries of health in development and training. And I'm going to take examples from my own experience and colleagues' experience from those partners in Zambia, Uganda, South Sudan, Zambia, Mozambique, Nigeria, and Malawi. And it's not really to point fingers, it's just to use that learning experience for better future. Next slide, please. So in terms of initial engagement, I wanted to highlight three successes which were quite key to establishing those initial relationships. And it's the establishment of a technical working group or task force was particularly well done in Uganda, Mozambique, and Nigeria. And in Nigeria, there was particularly good collaboration between partners and the MOH to produce a set of guidelines that really informed the materials development process. And that process was producing one set of materials, which is led by the MOH rather than partners producing their own sets. Also building on in-country materials that already existed and building on existing country programs. So for example, IRC set off with implementing iCCM and developing their own set of materials, and that was actually adopted later by the MOH in South Sudan. Having a agreed set of terms of reference for a harmonised approach with a clear plan for development and agreed roles and responsibilities. And there was also a very constructive discussion on the technical content between the implementing partners, which really influenced the technical quality of those manuals and materials. There was also supporting partners to MOH exchange visits. And it was really the participation of partners from Uganda that promoted cross-country learning. And a visit from Nigeria to Uganda really had a positive influence on the materials development to see all the good work that was being done in Uganda. In Malawi, there was a particularly good partnership between MOH and the implementing partner, Save the Children, where there was apparently no distinction between Ministry of Health staff and Save staff, as they worked really harmoniously together. Next slide, please. A few lessons to be learned, as always. There needed to be really, even though there was a task force in place, there needed to be properly defined ways of working. For example, having agreed values, principles, and processes for decision making. In some instances, the decision making process kind of fell apart where no one person wanted to really make that decision. Also, there needs to be more dialogue in the approach and process to initial partner engagement. So you have to remember that Ministry of Health is at the centre of this, and that any technical partner needs to be formally introduced and endorsed, and really explain what they can bring to the process. There needed to also be more, the partners actually needed to be more convincing in some cases with the evidence base on iCCM. We know it's an extension of INCI, but there was a tendency to hire consultants to work on the manuals and use the WHO template, manual template, and there wasn't really enough adaptation. Health workers have much lower levels of literacy than frontline health workers, for example. There needed also to be earlier buy-in from the Ministry of Health in one country. There wasn't really that early engagement between all partners having a unified approach to present to the MOH, and the MOH really only came in much later when they realised from a learning experience in Nairobi that they needed to be much more engaged, and then partnership collaboration kicked in, but it happened eventually. eventually, but the lesson is to have it from the start. One really real success from South Sudan actually was there was a secondment of an implementing partner member of staff to the MOH to find the right person to roll out the effort in roll out quality iCCM and to lead in that. Unfortunately, that person was seconded to a different department, but the lesson is, it's worthwhile to do that and to try and keep that person there. Okay. So next slide, please. In the development of training materials, there were many successes. There was a strong methodological approach, lots of use of adult learning principles, participatory facilitation skills, seemed very well done in Uganda, South Sudan and Mozambique. There's a real emphasis on building the competencies of CHWs, learning by doing, demonstrations, role plays, and taking the CHWs to clinical sessions in outpatient departments in hospitals so they could practice their skills on real children. There was also a rigorous pre-testing of the communication materials and the job aids, and that's really done well between the MOH in Uganda and Mango, which is a graphic designer in Mozambique, Zambia and South Sudan. Those materials were really pre-tested to the context, and making materials context specific was very well done. There was also great sharing of research to improve the technical quality. IRC shared their beads that count the respiratory rate for measuring the respiratory rate, and we really tried to ensure the quality through the cascade system. So we didn't just train the master trainers and leave the master trainers to train the district or provincial health staff. We made sure that the master trainers accompanied those different cadres throughout the whole cascade. And through the use of competency checklists for trainers, which we've developed some trainer competencies, we tried to ensure that the trainers really developed their participatory facilitation skills, and they had feedback and observations from the master trainers throughout that process. So we had a good cadre of trainers at the end of that process that could be used for other interventions. There weren't really lessons, but recommendations, things that could be done in all countries. So the importance of pilots and field testing the training materials, so from training of trainers through to CHW, and that's the manuals as well as the job aids, to road test them to see how they work before full rollout. And then involvement of district level trainers and master trainers in the materials development. So it's not just done by consultants, but the trainers sat around the table, tried out activities like the pilot training of trainers, and really fed into the development of those materials in Uganda and Malawi. That's particularly well done. And having half partner and half MOH training teams work very well, and that was really done well in Uganda and Malawi, training as one team. In the actual implementation, again, there was piloting of the training of trainers course and the CHW trainings, and that was done well in Uganda and Mozambique. And the use of job aids that really do promote learning and retention and memory of the CHW task and responsibilities, as opposed to a more chalk and talk approach. Training was delivered in local language where possible, and they have multilingual training teams, which is particularly important in South Sudan, where you might have three different languages spoken in the same room. And there was various lessons learned from that, where there was sort of trial and testing of training in one language and then translating, and it is just too long and cumbersome, and you could lose the attention of your learners very quickly. So having multilingual training teams was the way to go. And joint planning meetings between MOH and partners really involved everyone in the process and had promoted shared responsibility for the process. In terms of lessons, it was quite a harsh lesson in South Sudan that we learned that we did need to included pilot training for CHW level, not just training at trainer level. I'll come back to that point in a minute. And also a harsh lesson was to actually contract health workers as trainers for a full-time period by the partner NGO. And that I'm just talking about in fragile context because the harsh lesson that we learned was during the first phase of training rollout, we trained 24 trainers and they remained within the health system. When we came back at a later date, only 3 of those trainers were there and everyone else had left. So just to really impress the point that consistency in quality, you need your same trainers if you're investing in them. And remembering that teaching new methods, such as using job aids and using visual materials for low levels of literacy does take a lot longer. And, I think the time factor has been miscalculated in some instances, so that the training time wasn't enough and training had to be extended. Proposed implementation successes. Because we haven't carried out a pilot CHW training, we went back and thought we need to really double check what exactly has been learned with, especially in South Sudan with people of such low levels of literacy. I mean, over 90% of our learners or CHWs couldn't read or write anything. So that was carried out as part of a midterm review into South Sudan and Uganda. And it became apparent that we needed to do another phase of training and have a full review of the materials to make them even more visual. And as a result of that process, there was a success in producing a set of gold standard materials with very low levels of literacy, and those have been shared and peer-reviewed by partners in MOH. And a learning paper has also been produced. So the lesson is, really don't be afraid to carry out a full review of materials post-training. And it's a matter of conducting continuous evaluations and of the uptake of skills of CHWs, assessing their knowledge, their skills, their competencies after training. And that's in addition to supervision, because, as we know, training is not just a one-off event. And knowing that visual methods don't really need translation, and it's a very, very effective method for low levels of literacy. Next slide, please. So the conclusions are really that we need to make efforts to facilitate collaboration from the start, to support Ministries of Health in setting up an effective task force and technical working group. And that can come through, for example, a regional network of partners at MOH where sharing lessons learned from previous experiences could take place and also could create healthy competition between countries as well. One set of materials is ideal, led by MOH ideally. Being open to including what's been developed before from other contexts, but realising you need to properly adapt those materials to the context, and knowing that job aids really do increase memory and performance for very low levels of literacy, but also for contexts such as Uganda. And promoting a cycle of revision, extensive piloting, and retesting, reviewing is recommended because we know that it's a continuous process. So as Helen said, today I'm going to be presenting a case study on an approach to CHW supervision that became known as CHW peer support groups, and this is based on a child survival program in Rwanda. I'm going to see if this works. So just to give you a little bit of background in terms to the project that I'll be speaking about today, the Kabeho Mwana, which means Life for a Child project, was implemented from 2006 to 2011 with funding from the USAID Child Survival and Health Grants Program, and it was implemented by 3 international NGOs concerned worldwide, the International Rescue Committee and World Relief. The project covered 6 districts in southern and eastern Rwanda, which represented about a fifth of the country's population, or about 1.9 million people. And the purpose of the Kabeho Mwana program was really to build the capacity of the Ministry of Health to roll out integrated community case management in line with national guidelines. To do so, the Kabeho Mwana program trained over 6,000 community health workers in the national iCCM curriculum, and we provided tools such as a lockable box for storing drugs and supplies, cup and spoon for mixing ORS, flashlights, etc., required for the provision of iCCM. We also established a very strong presence in the field to be able to provide ongoing and intensive technical support to each of the 88 health centers that were involved in supporting iCCM rollout. In addition to all of this, we also implemented intensive community-level behavior change and community mobilization strategies designed to create demand for iCCM services. So before I get into the support groups that we developed, I think it's first important just to understand what the overall community health structure in Rwanda looks like. And I'll be speaking about this today specifically as it relates to iCCM. For those of you familiar with Rwanda, you know the community health structure there is quite robust, so I'll just be focusing on the iCCM components today. So at the village level, there are 2 CHWs, 1 male and 1 female, called binomes, and they are each responsible for providing iCCM services at the village level. The next level up is, of course, the health facility, where in charge of community health is based. This person is responsible for supervising all CHWs and all iCCM activities in her health facility catchment area. There may also be 1 or 2 CHW cell coordinators. Cell coordinators are CHWs that have been elected by their peers, and they are responsible for the compilation and submission of all of the CHW reports to the health center. And then finally, at the above that level is the district hospital level, where there's also an in charge of a community health supervisor. We'll just be focusing on the bottom 2 levels today, but just so that you can see the full chain of command. So now that we have a basic understanding of what the community health structure looks like in Rwanda, we'll consider the specific implications for CHW supervision. So as I described in my last slide, CHWs for neighboring villages are grouped together into cells through which they organize a cell coordinator. Each cell consists of approximately 100 to 300 CHWs, depending on the number of villages under the health facility catchment area. So for today's purpose, we can perhaps assume that this health facility has a catchment area of 100 villages, and this would require 200 CHWs, 200 genomes providing CCM. So as you can understand, providing supervision to all of these CHWs would present a huge challenge for the facility-based in charge of community health. And I think this is an issue that a lot of us grapple with under many iCCM programs. The community health in charge is expected to conduct quarterly supervision visits to each CHW in her catchment area to check their drug stocks, appropriate storage and drug management, review the CHW register, assess quality of care by observing the CHW provide treatment to a sick child. The community health in charge may also visit children that have been recently treated by a CHW to assess the quality of care that they received. In addition to this, cell coordinators are also encouraged to conduct monthly peer support or peer supervisions to the CHW. Incredibly, in Rwanda, each health facility does receive some funding from the central level to support supervision, to support the community health in charge to cover their per diem costs and maybe some transport. However, even with this support from the MOH, there's still a number of challenges that prevent the health facility based in charge of community health to get out and do her supervision due to logistics, not enough transport, and just quite simply, not enough time.
what we found was that often the most frequent contact that the in charge of community health would have with her CHWs was when they would all come to their quarterly sub-meetings at the health facility and not actually out in the field. So, back to the Cabello Mono program. In order to encourage and help facilitate CHW supervision, the program created CHW peer support groups. These were originally based on the care group model, for those of you that are familiar with that. I won't go into it today. I'll just say that the care group model evolved over a number of years to just consist of community health workers. The peer support groups consisted of an average of 20 CHWs, which was about CHWs from 5 to 15 neighboring villages that would come together, and they would meet once a month for training on health topics, joint planning of health promotion activities, and to compile reports together. And a total of 660 of these peer support groups were formed throughout the program area. The CHW peer support groups were facilitated by the self-coordinator under the supervision of the health facility in charge.